Children and Families Committee to order, and I've asked Senator Payne to bring us a devotion. What's your mic number?
Number 11. Let's bow our heads in prayer. Heavenly Father, we come to you today, Lord, and just thank you so much for all the many blessings, Lord. And as we come on this day, for this meeting, for the first meeting ever of the Senate Children and Families Committee, we just ask you to lead us and guide us in all things we do, that we would better serve youth and families across Georgia. Lead us and guide us in all things we consider. For us in Jesus' name we pray. Amen.
Thank you. Welcome, everyone, to the Children and Families Committee. Before we go on with the meeting, we have to adopt our rules. I hope that you guys have looked over those. There's nothing very controversial in there. And I would entertain a motion if anybody would like to make one.
I'll make a motion to pass. To adopt.
Is there a second?
I'll second.
Okay. All in favor, please raise your hand. Okay, we've got rules. Thank you. Let me just kind of set the stage for what we're doing today, because there may be some people here who were coming about a bill that is no longer on the agenda, which is Senate Bill 64. That bill has been delayed until next week at the request of the sponsor. And so if anybody's here just for that, you can feel free to pursue your day. We're going to have two presentations in our committee today, both of them fairly brief. One is by Dr. John DeGarmo from the Foster Care Institute, and one is by Dr. John Constantino, the Chief of Behavioral and Mental Health at Children's Healthcare of Atlanta. And then we have one bill on our calendar, which is Senate Resolution 76, which is actually my resolution. At that point, I'll turn the gavel over to my Vice Chair, Senator Hatchett. So with that, Dr. DeGarmo, you can sit right there in that witness chair, and I do believe we've got your mic on. And we have about 10 minutes, and then we'll have a little time for questions. Thank you for being here.
Well, my pleasure. Thank you for the opportunity, and I want to say thank you for all of you who are interested in this case, who are advocates for this case. You know, foster care. A little bit about myself. I'm Dr. John DeGarmo, founder and director of the Foster Care Institute. I've been working with foster care agencies and child welfare programs across the country, across the globe, author of several foster care books, but I've also lived the lifestyle of a foster parent and adopted parent myself of over 60 plus children in our state. I've had as many as 11 kids in my house at the same time, because there's not enough children. There's not enough homes for these children. In fact, one Christmas I had 7 in diapers. You can imagine how smelly that Christmas day was. I've had the blessing of adopting 3 children from the foster care system. 2 of those 3 are third-generation foster care, which means their parents and their grandparents were also in the foster care system. The system failed them, and their biological mother was prostituted out by age 9 in small Shadydale, Georgia, population of maybe not even 1,000 people. Happens in every single community. Foster care has been in crisis for quite some time, not just because of the hoteling, and I'm very glad for your advocacy in that regard, but it's been in crisis for some time, not only in Georgia, but across the nation. To begin with, we have more children coming into a system, and there are not enough foster parents. Now, as a foster parent myself, I'll tell you, it's been the most difficult and challenging thing I've done. It's also been the most rewarding thing I've ever done as well, and every child's made me a better person in some way. In my house, there's no label, there's no foster, biological, or adoptive. They're all my children, and I love them unconditionally. That's what good foster parents do. But there's a foster care crisis. So more children coming into the system, perhaps due to opiate epidemic, perhaps because of Roe versus Wade, perhaps because of the border, perhaps because it's generational. And there are not enough foster parents. We did a study at the Foster Care Institute a few years ago. We surveyed 5,000 foster parents across the country, and we asked them, what's the number one reason why you are quitting, on average, about 18 months into foster parenting? And by far, the number one reason they said was foster parents felt like they did not get the support services that they needed. And I can tell you that's quite true. At the same time, our caseworkers are truly overworked, overwhelmed, under-resourced, under-supported, understaffed, and underpaid. So it's a very challenging aspect in that regard. So how do you fix this foster care crisis? And it goes well beyond hoteling. That's just a small aspect of it. And I've had, as I said, 11 children in the house same time, and the limit is 6. I've had many teenagers in my home, so I know what it's like. So how do we fix this problem? Well, to begin with, we need to make sure the children and the youth are getting support services that they need. When a child is placed into a foster care home, maybe like my own, you can put aside all their anxiety, their trauma, their abusive experience. It is a time of tremendous anxiety being placed into my home. Because when these kids come to my home, they ask questions such as, why am I here? When do I go home? Is it my fault? Did I do something wrong? Does mommy and daddy not love me anymore? Is that my fault that mommy and daddy touch me at night where they're not supposed to? And when I don't have the answers to their questions, because again, I'm a stranger to them and they think I might hurt them any moment, what do they do next? I'll tell you what they do. They cry themselves to sleep at night. And I've held so many children and teenagers in my arms during those first few nights as they've cried themselves to sleep. It's a time of anxiety being placed into care, no matter how structured and stable and consistent and safe and loving that home might be. It's a scary time. So for these children and these youth and these teens that we're talking about in hoteling, they need to make sure they get the proper therapy and counseling services while they are in care. They need to make sure they get those services while they go out of care too. Reunification, of course, is the end goal of foster care. 50% of kids in foster care are reunified. Of that 50%, 20 to 30% come back into care, and I've had it in my house, for a number of reasons, many times far behind, filled with even more trauma, filled with more anxiety. On average, 55% of youth nationwide, when they age out of the foster care system or transition out of the system, will drop out of school. 55% will drop out of school. Children in foster care struggle with reading and math skills, and they're 18 months behind academically on average. That was the center of my doctorate, actually, was foster care in schools and education. When a child is moved from one home to the next, and from one school to the next, they fall further and further behind in education and in school. So it's no reason there's no wonder why when they reach the age of 18, they say, I quit, I'm out of here. In addition, 65% will end up homeless, 75% will incarcerated, and like I said, many times it's just generational. So we need to make sure they get the school services they need as well. But kids in foster care, many times the school system is not the right place for them. So they need to make sure we get the right support services that they need where they are at that time. So along with therapy and counseling sessions, we need to make sure our foster parents are getting the right support services and that they're properly equipped to care for the kids and the youth in their place in their home. Otherwise, they are quitting. And we saw record numbers of foster parents quitting during COVID. I was hearing from across the country when the children were stuck at home, they were not going to school. They were struggling with, no longer were they getting the support services they need. They were not getting the services from school. They were not getting the therapy sessions they need. We're not getting visitations they need. Their anxiety levels raised through the roof. In addition, foster parents, their anxiety levels went through the roof as well. So we lost a lot of good foster parents. So we need to make sure they're properly trained, supported, and equipped with skills to make sure they're with positive parenting skills, parenting troubled teens, anger management, the list goes on and on. We need to make sure our caseworkers as well are getting the support services they need. And one way we can do that is to make sure the caseworkers have a lighter load. Because when you have so many children on a caseworker's caseload, and they have paperwork, they have meetings, they have all on their plate. Again, they're overwhelmed, overworked. They don't have the time to work with the children. They don't have the time to work with the foster parents. They don't have the time to work with the birth parent, the biological family members. So they need more help. But you know what? In truth, DFACS can't do it alone. It's such a huge problem. So we need to bring in outside sources. I was just in Iowa 2 weeks ago, speaking to a number of churches in that state about creating their own foster care outreach program, foster care ministry. The truth is, as we're having this meeting right now, there's a child in every single one of your communities, probably within a mile of each of your homes, who at this very moment is crying out, somebody please help me, praying, somebody please help me. 5 million children experience domestic violence in their homes every year. 800,000 children missing. 300,000 children victims of human trafficking. About 400,000 kids in foster care. That means it's every single community, and DFACS, the government, can't do it by itself. So we need to bring faith-based organizations online. We need to get schools online, professional therapists online. It's a much bigger problem than just hoteling. And I often tell people that I can't change the world and that you can't change the world. But when we provide the support services, the resources, and equip the caseworkers and foster parents with the help that they need, they can better help the kids, and then the children's world is changed. And that's how we do it. I'd love to entertain any questions you might have. I'm driven daily to make the system a better one because it's failed so many of my own kids. I've had 4 failed adoptions, and you can imagine what that's done to our home. So I'm very, very driven to do this, and I'm so glad that you're here to bring awareness to this. I know that everybody can't be a foster parent. Again, it's the hardest thing I've done, but I also recognize that everybody can help in some way, and awareness equals advocacy. So I'm grateful for what you're doing, and I'd love to answer any questions you might have.
Questions from the committee? I want you to know, Dr. DeGarmo, that we're committed to continuing to study this in the Senate. So this is just the beginning of a complicated and long conversation. But thank you.
But I do want you to know this before I go. The foster care system can be fixed. It can be repaired. It can be strengthened. It can be reformed. So I'm grateful for you who are prepared to do that.
Okay, we do have a couple questions, so
Please,
don't leave.
absolutely, yes, please.
Senator Jackson.
Yes, thank you so much for being here and for all of your work on behalf of all of the children of Georgia. I've heard some constituents talk about wanting to become foster parents, but that the requirements and rules for becoming a foster parent have been so burdensome in terms of even needing to making modifications to their homes, not being able to keep family pets. I've heard that kind of one off, two off here and there anecdotally. I'm wondering if you have any more information around that, and what you see is maybe there are some modifications that we can make around that as well.
You know, it's a great question. And along with that, there's so many myths and misconceptions associated with foster care as well. I hear from so many people, I can't do what you do. It hurt too much to give the kids back. Well, that's actually how it's supposed to be. Our hearts have to break for these kids. There have to be in place requirements for foster parents. Sadly, and we've seen the stories, there are some tragically bad foster parents. So we need to ensure that when a child is placed into a home, that they are safe mentally, physically, in all regards. So can there be modifications? To be sure. And that's something that can certainly be discussed, and I've worked with it. One of the things that I do with the Foster Care Institute is I help agencies on both recruitment and retention to recruit new foster parents, but recruitment and retention go hand in hand, because if you recruit 10 great foster parents and 8 of them quit within 18 months, then your retention efforts are wasted. Same with caseworkers. But it's so important to make sure the kids are placed in stable homes again, otherwise we see those bad cases. I appreciate you asking. Thank you so much.
Okay, Senator Hatchett.
Yeah, thank you, Mr. Chairman. What's the biggest area of improvement that you would want to see in the foster care system for the children or the parents or defects? I mean, what's the top of the list issue that you see right now?
I see there's a 2-part correlation, if you will. The foster parents have to get more support and be better equipped and better trained so they can care for those children. My first placement was at 10:30 at night, and I recognized in 20 minutes of my first placement, I'm not ready for this. I'm not prepared for this. And that happens to a lot of foster parents. But at the same time, they're not getting the support services they need because our caseworkers, our social workers, and DFACs are overworked, overwhelmed, and under-resourced, understaffed, underpaid. So we need to bring that foster parent caseworker level closer, so caseworkers have less foster parents on their caseload, so to speak, so they can provide more support services. When I've got that child at home at home at 3 o'clock in the morning and there's an issue going on and I can't contact anybody, that's a problem. That's when a lot of foster parents say, I'm out of here. So more kids coming in, not enough foster parents. How do we retain our good ones? Well, they need support. They need to be better equipped, better trained. But how can our caseworkers do that when they're simply overwhelmed by the amount of children coming in, the paperwork? So that's where I see it needs to be the beginning of this journey.
So you're, I guess the biggest thing you see is we need more social workers or DFACS employees, or who is it in particular that you think we need?
Yes, we need more caseworkers. I'm hearing from
caseworkers.
Yes, social workers. Yeah, they go ahead. Yeah, and I'm seeing that not only in Georgia but across the country. Kansas, Kentucky, right now. These are states that are saying we need more. I appreciate you asking. Thank you so much.
Yeah.
Thank you.
Again, that's just one part. There's so much more.
Yeah.
Thank you.
Senator Estevez.
Thank you, Chairwoman. Doctor, I want to tease out a little bit more the support that you
Yes,
talk
please.
about foster parents needed. Can you tell us what support foster parents currently get, what's needed, and what potentially we can do about that support that they're receiving? I hear you say shortage of staff to do the training, but
Sure.
can you talk more about
Sure.
all that?
So as I just mentioned a month or two ago, my wife's got a degree in psychology. We became foster parents because of the death of our first child. My wife, our first child had anencephaly, or some pronounce it anencephaly. It's a condition where the brain and skull doesn't truly form. My wife was in labor for 92 hours, and I turned my back on a lot of things. That's when we were living in Australia. Moved to Georgia, became a teacher, working in a very rural school system in Edenton, Putnam County. We had 3 healthy children. Both my wife and I have been leading a life of service. So we thought we were ready when we were foster parents. We thought we had seen it all. And then again, first 20 minutes, I recognized I'm not prepared for this. And so many foster parents aren't. They're not equipped with, when a child comes to your home with a reactive attachment disorder, disinhibited social engagement disorder, eating disorders, teens. I remember my first experience with my first, if you will, meth baby. So foster parents need to be better trained and equipped so they can help these children. Because when I had that child in my house who was screaming or yelling because of anger issues, how can I address them if I've not been properly trained or equipped to do so? So many times I say, this is so hard, I can't do it anymore. But if the foster parents are getting the training they need so they can be better equipped and the support services they need as well. No, listen, I've written 12 books, traveled the world doing this. My own family members look at me and say, why do you do this? So and the only person who really truly understands a foster parent is another foster parent. They've got to have some type of support, whether it's from DFACS or faith-based organizations or school systems or people in the community.
Thank
It's
you.
a great question.
Senator
Thank you so
Merritt?
much.
Thank you, Madam Chair. Because I am interested in hoteling, I know you specifically said that is one piece.
Yes.
And I'm getting that part of the problem is we don't have the foundational support for our foster care systems with our families. I know there was a move 10 years ago. There was a big plan for this whole deinstitutionalization. It was supposed to happen here in Georgia to move towards community-based. So as we started closing mental health facilities, we had nowhere to put people.
Yes.
And now we're 10 years here. This is the fallout is part of this. Now we have nowhere to put kids who need help. So my question is, I get you're giving us some things we can do to support the foster parents, but what can we do that would be impactful so we can stop hoteling kids like today? I'm looking for solutions there.
I remember I was in Iowa speaking at an event, and my wife had a phone call for a 12th child, and child welfare saying, please, can just sleep on the couch. And my wife said, how can I take 12 kids to school the next day by myself? We simply can't do it. They're calling us because there's not enough homes for these kids. So that child had to remain in a hotel. And did I feel guilty? Absolutely I did. For me to give you a 1-word or 2-word answer to fix this problem, I can't do that. It goes so much deeper than that. It is, this is not, when I was in D.C. recently, I was telling people this is not a goods and services. These are children. These are real people, humans that are crying out this very moment. So how do we help them? It goes much deeper into a couple words. How do you stop the hoteling? Well, you need more foster parents. They need to be better trained, equipped. So they'll say, I will take that teenager. A lot of foster parents will not take teens because of the stigma associated with it. One of the trainings that I do across country is parenting troubled teens, because many foster parents will not take teens. I hear this from agencies all the time. How can we get more foster parents to take teens? They need to be better equipped, better aware. I think that's where you start.
So if I can follow, so would it be more advantageous for us to start putting more funding towards the supports that you're talking about to help the foster parents versus what we're doing now because it's not working?
I think that's part of it. Years ago I met with Bobby Cagle, who was in charge of defects at the time, and we were in discussions about doing a 7-pillar step on helping foster care in the state. And then he would move to California before we get further discussions. And one of those ways, we talked about hoteling, and we talked about how do you stop this, and that is getting more foster parents say yes to these children. But then foster parents are not going to say yes again if they feel they're not getting support from DFACS. When I call up DFACS and all I'm getting is a recording, an answering machine, and I need help urgently, well, then I'm out of here. That's what many foster parents say. Thank you. Yes, thank you for asking, and I appreciate your advocacy.
Thank you very much for being here, and I'm sure we'll be continuing the conversation.
My pleasure. Thank you.
And next, while Dr. Constantino is coming up, we'll put his presentation up. He's got a PowerPoint. And then, meanwhile, I'd like to introduce Commissioner Brose, who's standing back there in charge of Department of Human Services. If you just wave. Thank you. Thanks for being here. Okay, Dr. Constantino, you're on.
Well, Senator Kirkpatrick, thank you very much for the invitation to come and deliver a short presentation and an impossible act to follow. I as a physician, child psychiatrist, I endorse so much of what Dr. DeGarmo just presented, and I'll mention that through my remarks. So I am the system chief for behavioral and mental health at Children's Healthcare of Atlanta. It's a new position, and a professor in Emory University. And the reason that I came to Children's Healthcare of Atlanta is that Children's Healthcare of Atlanta has made a decision and a commitment as an institution to do everything it can to deliver mental health care to children on a par with what they generally deliver for medical care for children. And this is a daunting task, and it relates back to the last conversation, because the burden of mental health in a population, mental health conditions in a population, is very substantial and weighs heavily in the foster care population of children. Just a little bit about my background. I was a past chair of the Mental Health Commission of the state of Missouri. I worked for quite some time at a state psychiatric hospital for children, and I was a professor at Washington University in St. Louis and the chief of psychiatry at St. Louis Children's Hospital, and a researcher. One of the things that, one of the most recent studies, which will be coming out soon in Journal of Pediatrics, was a prospective study of 600 infants and toddlers in foster care, and to cite Dr. DeGarmo's statistic about the fact that after the kids are reunified, that 30% of the time they come back into care. We showed that if you just deliver mental health services, standard mental health services to the families and the children as needed, you drop that to 4% return to the court system, 10-year follow-up of 600 families in the system. So I share Dr. DeGarmo's hope that things can be done. He also mentioned the issue of the caseworkers' caseloads. The Annie Casey Foundation showed years ago that if you just cut the ratio of children to caseworkers in half, the improvements lifetime as adults in reductions in substance use, delinquency, crime, and enduring mental health conditions is very substantial. By the only revision of changing the caseload number of the caseworkers. So I think there are definitely some areas of hope as far as that's concerned. As far as mental health, our niche is trying to provide mental health to children, and certainly also to coordinate great strategies for mental health for parents, because you can do all you want to help the mental health of a child, and if their parent has an unmet mental health need, then you're not doing much for the outcome of that child. Unfortunately, it's the best laid plans get dismantled. I'm sorry about, I didn't know how the projection would turn out, so I'll kind of talk through this, and I'm glad to share the slides. But I want to make the point here that mental health care for children has advanced over the last 20 years. There is a discrete, short list of evidence-based interventions that actually work, and most children don't get them. They have not been incorporated into our health system. And so children languish without interventions that could change the course of their lives and protect them from major adverse life outcomes, such as foster care placement, in the situation of their parents having unmet mental health needs, such as delinquency, crime, substance use impairment, teen pregnancy, school dropout, and enduring long-term mental health conditions. And so what are all those evidence-based elements of care? There are things like cognitive behavioral therapy, psychopharmacology when you need it, various types of intervention and care coordination for therapeutic interventions that we know have substantial benefit for reducing the impact of children in crisis. And they're distributed in different systems that we have around, in the community. This is a little graph of how we have different bureaucracies for where mental health care is actually delivered. Primary care environments, schools, communities, outpatient mental health services, acute inpatient services, residential services. But they are greatly disaggregated from one another, and none of them are wide enough to actually fill the need for the population. And when you think about the fact that evidence-based mental health services, which should be part of medical care, are not being incorporated into health, it would be like saying, if a kid has diabetes, we'll just treat part of it, or we can only treat 60% of the kids with diabetes, the rest of them have to languish. And so what Children's is thinking about how to do is close the gaps. These are gaps. If you think of the x-axis as all kids that have mental health needs, and the y-axis is what happens when they grow up with mental health needs, those blocks will protect them from landing in the municipal safety net. Places where primary care, community outpatient services, and so forth will attend to children's mental health needs on time and prevent them from landing in the safety net. Our safety net is massively overburdened, including what Dr. DeGarmo talked about, because these needs are not being met and these gaps exist. And we really have to think about how can we close these gaps, capitalize on federal laws and state laws for mental health parity, that mental health services that we know are medically necessary should be delivered on a par with medical services, and close those gaps so that our safety net is not burdened in the way that it currently is. So right now, some kids are caught by these services, but lots of kids fall through the gaps, end up in the safety net, and what we need to do is close those gaps across the domains in which mental health care is delivered to children. Children's Healthcare of Atlanta is poised to do its job, to increase in a very substantial way its capacity, but there's 2.5 million children in Georgia, and we're only going to be able to do as much as what falls within the niche of a medical health system, and we want to help and support and rely on our partners in schools, in primary care settings, our community outpatient partners, our partners in acute crisis stabilization and psychiatric rehabilitation or residential treatment facilities, to really close the gaps that exist, to really provide an ecosystem that basically looks like what happens if you grow up with cancer, or you grow up with diabetes, or you grow up with asthma. There is a medical system to attend to that. It's not perfect, but it's so different than the mental health system. In our mental health system today, 90% of what we pay for is 7 years after the start of a condition and after a crisis has already happened. 90% of what we're paying for. We have to try to turn that around and get in front of these conditions. And also in this country and in Georgia, 30% of all children's mental health is self-pay, because the parents know, I can't get this on my insurance. I can't even find it. I can't get access to it. And guess who doesn't get to self-pay? It's poor kids, Medicaid kids. Children's Healthcare of Atlanta has a 60% Medicaid population, and it intends equitably to deliver as much mental health service as it can. That's the green on there, to increase its capacity, and we want to work with our partners in the community to close these gaps. So we're going to not just concentrate on crisis care. One of the things that we're going to do for crisis care in this community right away, starting this spring, is that there's many kids who land in our emergency department, 5,000 a year, in behavioral crises. We keep 13% of them in Children's Healthcare of Atlanta hospitals. The rest are going out to the community, to crisis stabilization unit, inpatient facilities, and so forth. But half of the time, after they're 5 days in an inpatient unit, there's no place to send them to recover. It takes months to recover from a crisis. We are going to start delivering that kind of crisis care to help our partners in the inpatient realm to have a place to discharge the kids to, so that they're actually recovering and not just parked for a few days until the acute crisis settles. So I think what we want to do is think about how can we work together to close these gaps. One of the closure of the gaps has to be that providers have to be drawn into the game of providing these services and increasing capacity for mental health care. inequity with medical care, and that means some of the rates are going to need to go up because the rates are what are driving people out into the self-pay market, and they get trained and then they're gone, and no Medicaid patient will ever see those providers. We need to make sure that the capacity that we do have is being used well. Currently in Georgia, for our most severe kids that need residential treatment facilities, 1/2 of our current beds are occupied by out-of-state kids. Because, it's more, the facilities need that revenue to make ends meet. And we need to make them whole so that they can see Georgia kids and do the job, to take care of our kids. And we need to coordinate care, because to keep this fragmented system, instead of working together, when I showed those evidence-based modules of care, there's many kids that don't just need one thing. It's just like a cancer kid isn't going to get cured from one chemotherapeutic agent. You need a cocktail, or you need a succession of treatments. It's the same in mental health. And mental health conditions are chronic. So we have to string together everything that you need to get better, as we did for those infants and toddlers and their parents in foster care. And when you put the whole package together, you get results. If you leave it fragmented, you don't. And so coordinating care in that way is very, very important. I'll stop there. Happy to entertain questions. I hope I didn't overuse my time. And again, Senator Kirkpatrick, thank you so much for the invitation to meet today.
Thank you very much. We do have several questions. So, Senator Estevez, you're up first.
Thank you so much, Madam Chairwoman. Thank you, Doctor, for what you're doing and what Cho is doing on tackling behavioral mental health in our children. Question/comment. I want to highlight and reinforce the fact that 90% of the services are being provided 7 years after. Can you?
In this country, the average timing of the implementation of a definitive treatment for a mental health condition of a child is 7 years after it starts. Okay? So we're waiting systematically until a catastrophe happens before we actually act on that and implement our evidence base. Now, in fairness, we didn't have this evidence base 20 or 30 years ago. I've been in the field for 25 years. I contributed to this evidence base and watched what we were doing to advance the evidence base basically not get used. And so that's why I'm here. Like I was okay in St. Louis and we had a good, program, but the system, the health system was not owning the advances in the field and saying, this is how we're doing business for children. And so this was an organization that was willing to step up and try, and this is a state where you just passed mental health parity legislation, and the convergence of that opportunity seemed to me, for the useful career that I have left, that this is the right place to be. And so that's what we're trying to do.
Yeah, so 7 years after, by then, it's late, more expensive.
Yep.
More intensive supports,
Yes.
Which costs
Wait.
insurance companies, families, the system.
Correct.
It taxes the system.
Right.
So when we think about our crisis centers, they would be alleviated by investing more on the front end. Things would be cheaper more on the front end if it was done on the front end.
Yeah, this is the point about burdening our safety net. That, with these gaps, the kids are falling into crisis, not getting any better. Everybody knows that. And, ostensibly, the suicide rates are going up, and the presentations into emergency departments are going up. We're going in the wrong direction as far as that's concerned.
And the last question, really quickly, that takes a change of perspective from all of us, right? Because even in education, health, we're kind of used to dealing with the acuteness and the crisis and trying to fix things versus dealing with the root causes.
Right. Well, the gut check is actually training a parent, which is an evidence-based intervention. Should that be considered health? But the consequences of not doing it, or not home visiting a fragile family, or not treating a parental mental disorder is an absolute medical crisis in a child. So are we going to own that or not? And my vote is yes, because the end game of that is the mental health of a child and the life of a child, literally. And so if that's what the health system is supposed to address, then you have to get serious about these, social determinants and the levers that we actually have to change those trajectories. Yeah.
Thank you. Senator Payne?
Thank you, Madam Chairman. This is, for 30 years I was a caseworker started out as what we called Department of Children and Youth Services before we became the Department of Juvenile Justice. So I looked at our jobs that we were DFACs that dealt with the kid. You know, DFACs dealt with the family, we dealt with the child, and we were social workers, the same as DFACs, and just had the same training and everything else, and our passion were the kids and trying to get them back on the right path. How do you make, my question is, you know, just what I saw in my office every day, and I always tell people, I said the kids are not the problem, they're always the result of the problem. And in so many cases, how do you make the generational gap, that generational gap in the family, that you're dealing with the kid that's, you know, within that 7-year window that you're talking about, since, you know, they've had issues since in their need and treatment, but how do you make that, because courts have very little discretion over punitive action toward a parent when the child is the one that's been charged.
Right. The child is left holding the bag of all of that. So when you're trying to get out in front of those situations, I think it's a real problem when, you know, the crisis has happened, a child has already diverted to that kind of pathway of delinquency and all the things that are going on with them. But every one of those kids that were in your system started off as an adorable, you know, kind of preschooler. Right? And you have to think about them like that. And then what happened to turn them into an adorable preschooler into somebody who's, you know, wrecking the place? And that trajectory requires the defragmentation of effort, not only across different systems for children, but absolutely for their parents. And if we don't, and you know, I told the leadership at Children's Healthcare of Atlanta that 2-generation approaches, especially for the young, are the only way to go. If you ask Dr. DeGarmo what proportion of all the foster kids that he took care of did their birth parent have an untreated mental health condition or substance use disorder before they dropped into their home, or a developmental disability, the answer would be about 90%. And that's a fact. And so if parents are suffering from these conditions and not scaffolded or buffered appropriately when they have those conditions, which are medical conditions or neuropsychiatric conditions, and if we have opportunities to treat them that we're missing those opportunities, then we're playing into the fragmentation of, well, we only do children, we don't do adults. And Children's, you know, Healthcare of Atlanta has only done children, you know, historically. And I presented to them, we can't do this unless we start to figure out that we're going to include parents in the portfolio of the target of our services. Well, how are we going to do that? And it's different medical records. And I said, yeah, that's what we're going to have to figure that out. Because if we don't think about the transgenerational nature of these conditions, all mental health conditions, all behavioral abnormalities are transgenerational in nature. Why? Because, you know, 2/3 of the causation is inherited. This is a sad, you know, issue of humanity, that there is genetic liability for these conditions. They're nobody's fault. They're medical conditions. Bipolar disorder, schizophrenia, nobody wanted that. They're part of our heritage, our evolutionary, you know, gene pool that's part of us. And the people that have these conditions are taking one for the team for the rest of humanity, that we're part of that gene pool too. But then there's the environment and adverse life experiences. And one of the things that we have the most control over is to say, when a family is too stressed and the train is coming, we know actually can predict, like a barcode based on a birth record, families who are very, very high risk for catastrophic adverse life events, that they just things are going to fall apart and they need to be supported in a certain kind of way. So whether it's a mental health condition or it's a constellation of family supports, parent training, or the treatment of a parental mental health condition, we can do it. The system isn't set up for us to do it, but we've got to change the way we strategize getting to those kids.
Thank you.
Thank you. We're getting a little short on time, so Senator Mallow, you have some quick.
Yes, thank you, Doctor, for being here, and to our commissioner for being here as well. In Chatham County, we have a large issue because we're a regional community. So we have an issue when it comes to just the collaboration, where you have a lot of service providers, but there is no central record-keeping system. And so what I found by working with our chief juvenile court judge and our juvenile court judge is that they will see children on the docket. There's a need where they may feel this child has autism. They may make a referral from the courts, but it's a backlog of 7 to 9 months. They don't want to incarcerate the child in juvenile detention because they believe that they need to be tested and treated. And so what happens is then they make that referral, and then it's a tug and pull to get information from the school system, to get information from their medical providers, because nobody's sharing the information on the child. So when the judge is getting ready to look at, the information with the child, Department of Human Services is coming, the guardian ad litem, and everybody has a piece of the information about this particular child. But it's not in a central record system. And so finally they get to the clinician. And the clinician says, well, I have to order all these other battery tests because all these other pieces of information I don't have access to. We're on a different system than that hospital, and they don't share information with us, so we can't get that person's medical record. And then it falls back to the parent, if you want to get your child treated, to go and get that individual medical record and then bring that back to us. And what we have found is that's a burden to parents to say, I want to help my child, but I'm just ready to turn them over to foster care because it's too much for me. I can't find the help. Or they say the reimbursement rate for Medicaid for a provider is low enough where they say, we don't take Medicaid patients.
Right.
And then they say the provider who will take that may be the next county over for you. So for us, we have a provider in Statesboro, but they live in Savannah in Chatham County. So how can we address this in a way, and I've talked to our judges about this, where we have juveniles who have serious mental health conditions that need testing for autism, but the judge said if this was a gunshot wound, the system would take them, treat them in trauma, take them down to ICU, step them down from ICU, move them from ICU to the floor, from the floor to outpatient, and outpatient to a physician. But in mental health, they go to the hospital, they're back on the street. If they get arrested, they're in front of my bench.
Senator Mello, thank you for articulating one of the parameters of mental health non-parity. Okay, so you're absolutely right. And communication and sharing of information. Now, we have some opportunities with electronic health record systems that are starting to pervade and be standardized across all pediatric networks and so forth. I am in the process of begging for linkages between health data and state administrative data, because we can be an agent in helping to organize that information. There are some very clever ideas on the horizon about the use of passports and specific kinds of information sharing methods that are state of the art, that have been tested and validated in other communities, that I think we can capitalize on. But I want to tell you, I had that patient in my clinic Tuesday with autism, who had gone to the courts, and the judges mercifully said, we can't do this, and she needed to be in a hospitalized setting, and they can't take her and won't take her, and she's not eligible, and she's sitting at home, and I'm actually emailing and phoning. I am emailing and phoning the mother on a day-to-day basis, watching this whole thing play out, and we're going to try to find a way to get this family and this young woman the support that they need. But this is happening all the time. I do think the information management is a huge part of it, and it's a huge waste when we don't have that information coordinated. But there really are strategies that we can follow to pursue that, and I would look forward to collaborating on that, because essentially, again, one of the advantages of a health system and its Medicaid, let's say, payers, is there's a lot of information stored either by the payer or by the health system, and how do we link that with our partners in the rest of the system is very, very important.
Thank you very much. Unfortunately, we're out of time. We could go on for a long time with this conversation, but thanks so much, Dr. DeGarmo and Dr. Constantino, and this conversation will be continued. Thank you very much.
Appreciate the opportunity.
I'm going to ask Senator Hatchett to take the helm.
What is it? Senate Resolution 76. All right. Thank you, Madam Chairwoman. So here you have Senate Resolution 76. If you want to go ahead and tell us about the resolution.
This started a couple years ago, this conversation about training our youth coaches for under 14 sports. There's already some training that happens at the high school level, but our recreational sports, the coaches are volunteers and are not always trained on very important life-threatening conditions such as heat, illness, sudden cardiac problems, concussions, and so on. So there are some programs that have been developed, and in fact, in some states, particularly in Alabama, there's already a program that's well entrenched, and that has been working out pretty well. And that program is called Coach Safely, and that's kind of how we started down this road, but there are other programs as well that do this type of training. It's not very expensive, and it can be done online. And so this is really an urging resolution, and the reason that I brought it forward is because, one, there's an epidemic of youth sports injuries. Two, we know our coaches are not all being trained up to the level that they need to be on these acute medical situations. And three, there's liability for the state when we have bad things happen to young kids on sports fields, because a lot of these recreational sports take place on state property. So I don't think this is very controversial that we're urging youth sports organizations to consider training their coaches by using one of these widely available programs. And I think we have a couple people who want to testify on it.
Yeah, thank you.
Happy to answer any questions.
Are there any questions for the
Why don't we
Chairwoman?
take if you want, we could take the testimony and then I can answer any questions at the
All
end.
right, let's do that first. Let's go as Steve Card in the audience.
Good afternoon. Thank you for the opportunity. As you mentioned, my name is Steve Card. I'm the Executive Director with the Georgia Recreation and Park Association. So essentially who we are is we have 204 park and recreation agencies and over 2,000 professional recreation members that are part of our association. We offer a lot of training, a lot of programs, but one of our largest arms is youth sports that we offer. As you can imagine, we serve close to 200,000 coaches as well as several 100,000 youth athletes across the state. And in doing so, the one thing that I am proud of is that our association for over a decade, if they participate with us at the region or at the state level, we do have a certification that that their coaches have to do. But where I like what Senator Kilpatrick has done and her sponsors is it really does a better job of outlining what at the end of the day are volunteer individuals from our communities, right? And it helps them have a better eye to address situations that may come up with our youth. And as Senator Kilpatrick definitely mentioned, she mentioned a lot of the heat-related, a lot of the concussions, but per some of the testimony from our experts prior here, the other thing that I really like that is in this recommendation, as you will see, is the mental health and also the social behavior aspects of the education that would need to take place in this as well. You know, Senator Kilpatrick did mention we have a great partnership with Coach Safely. They are an approved provider, as we have several approved providers for our sports for our sports competition. So we look to be able to continue pushing this not only through our city and county park and recreation agencies, but also our YMCAs, our Boys and Girls Clubs, and our churches that are part of our association, as we look to make sure that our volunteer coaches are as educated as they can to be able to recognize some of these things to hopefully address them when they need to be addressed. And I'll be happy to answer any questions that you may have.
Thank you very much. Do you have any questions?
No question, just a comment.
Okay. Number 7.
As a mom who has had a son who's been playing youth sports football since he was 7, I really appreciate this because a lot of times our coaches they're just community moms and dads. And I don't think I've seen this level of precautions taken even in our youth sports. And we've had kids, fall out, on the field for heat exhaustion or just asthma related issues. So I just want to say, Senator Kirkpatrick, thank you for bringing this forward.
Thank you. No more questions there. Bethany Scherer with MAG.
Hi, I'm Bethany Scherer with the Medical Association of Georgia. I represent over 8,000 physicians across the state of Georgia, and we are just here in support of this resolution. We think it's incredibly important to make sure that we're protecting our youth who are playing sports, and as somebody who had plenty of experience with youth sports injuries, we certainly think this is very useful, and thank Dr. Kirkpatrick for bringing this forward.
Thank you. Any questions? Are there any questions for the author?
I just have one thing to add. You do have some letters in your folder, one from the Georgia High School Association, one from the National Council Youth Sports, and then there's one from the Andrews Institute in Alabama, where they have a lot of experience with this program. So thank you.
Well, there are no questions. What is the pleasure of, oh, hang on, we got one, Mike 12.
Ready to make a motion, Mr. Chairman.
All right, now's the appropriate time.
I move that we do pass Senate Resolution 76, LC 112-1238.
Got a motion, is there a second?
Second.
All right, all those in favor will raise their right hand. All those opposed? It passes unanimously.
It's a tough vote, man.
That's a tough bill.
It's tough in there.
So this is a historic meeting of this committee that was just established, a brand-new committee. I think we can expect to make a lot of progress on some of the really important issues for our state. And we're going to take a quick picture before we adjourn. Oh, Senator Burns, he comes in at the last minute so he can be in the picture. That's all he wanted. Thank you. And as I mentioned earlier, we are going to have a fair number of bills flowing through our committee, including 4 that were dropped today that have to do with sort of legal fixes that the Department of Human Services needs in order to improve what they do. And so it's very likely that we'll be continuing after the session is over and have some type of a study process that will be relevant to the subject matter that we covered today. So thanks very much for your attention, and we're adjourned.